Hello friends, are you ready for another one? Today number 25, the Pterygopalatine fossa, the palate and the oral cavity. So we'll be looking at the nerves and the arteries descending in the Pterygopalatine fossa toward the palate and the oral cavity today. A little lighter than other dissections, but you're probably okay with that. So the back of the Pterygopalatine fossa here is the sphenopalatine foramen. This is where the sphenopalatine artery enters the nasal cavity and then descends down into the palate via the greater and lesser palatine arteries, and the nerves go through here too. But if you haven't done this already in a previous dissection, I'd like you to take a blunt probe and break the bone just behind the nasal concha here. This will expose the greater palatine canal, which contains the greater and lesser palatine arteries and nerves coming down into the palate here from the sphenopalatine artery and the pterygopalatine ganglia. We've seen that previously, but we'll talk about the artery just for a moment here first. Remember that this is a branch off of the maxillary artery, which comes off of the external carotid. And this is going to enter the nasal cavity, again, through that sphenopalatine foramen. And it's going to give some branches here. The posterior lateral branches supply the concha. You can see those coming down here onto the concha. And then it's got a posterior septal branch. Remember that this picture is just a flipped image here. So they've kind of flipped it down so that you can see the inside of this right nostril on the septal side and the lateral side on the concha. So it has this posterior septal branch coming up this way, supplying the septum. And then it will also give, down here through that canal, it will also give the greater and lesser palatine arteries, which supply the hard and soft palate, respectively here. Remember that some of the septum is also supplied by and part of the lateral conchal wall here is supplied by the anterior and posterior ethmoidal arteries. And remember that those are off of the ophthalmic artery, which comes off of the internal carotid. So the carotid artery really supplies all of this stuff, either through the, ultimately through the internal carotid or the external carotid through here. Okay, let's look at that ganglia here. Remember, this is the Pterygopalatine ganglia, which is within that Pterygopalatine fossa. This is the maxillary branch of cranial nerve number 5, so V2, exiting the foramen rotundum in the skull and innervating the nasal cavity and then the oral cavity. And remember that there are, let's go to this one here. This one's maybe more familiar. We looked at this one last time. You've got the posterior superior and the lateral, the inferior lateral branches that supply the concha right here off of that ganglia. And then you also have the greater and lesser palatine nerves coming down here. Greater palatine nerve, just like the artery, is going to supply the hard palate. And the lesser palatine nerve is going to, just like the artery, is going to supply the soft palate back here. And then you also have this nasopalatine nerve that comes up here, supplies much of the septum before it kind of ducks into that incisive canal, which is right here. So remember that this is just going to be flipped down. So as it comes up through that septum, it's going to come through the incisive canal, which is right behind the front incisors here as it comes down onto that. So the greater palatine artery and nerve, the artery from this slide coming down here, and the nerve are going to come through, and they're going to go into that incisive canal as well. So remember that the septal branches, this septal branch of the artery is going to go into that incisive canal as well. I didn't mention that in this lecture, but we said that previously, I think. And then the arteries here come down and supply some of the palate, but then that greater palatine artery, as well as the nerve, are going to come in through that incisive canal and supply some of the septum here. So I don't know why there's that little bit of overlap between the two. Here you can see the greater palatine nerve coming up and supplying some of that, the septal branches here, but well, it's the way that it is. There's a little overlap in the septum, apparently, from a nervous and arterial supply. Now, if we go to the next slide here, we'll look at some of the palate, more of the palate here, the palatine glands. Now, hate to break your heart, this is not going to look like this. This kind of looks like kind of a pretty distinct orange peely kind of structure here. As you dissect the palate, it's not going to be nearly as clear or as large as Netter has drawn it here. This does help to provide some of the mucus that contributes to the saliva in our mouths, these palatine glands, but that's really not what you're going to be. This won't be a predominant item in your dissection that you'll notice today. And again, the greater palatine artery and nerve are going to supply the palate, the hard palate. The lesser palatine artery and nerve are going to supply the soft palate back here. So you should be able to find maybe some of those branches going to each of those structures. If we look back at the palatine tonsils here, we've touched on this previously. This is found within the tonsillar bed. These have little crypts, little valleys in them. Food, as you swallow, gets kind of brushed by these. When you swallow food, it kind of gets caught in there. Chewed food will get stuck in those pockets or those crypts. Kind of gross, actually, isn't it? And the bacteria there then breaks down, and you've got this ability to create a little bit of a microculture of the materials that you've ingested to give the lymphatic system a heads up and some time to prepare if there needs to be a reaction to what you've just ingested. And they call this Waldeyer's ring. You can see the three tonsils here, the lingual tonsils in the back of the tongue, the palatine tonsils just underneath that, kind of the soft and the hard palate back here, and then the pharyngeal tonsils, remember the adenoids way up here. These are all lymphatic tissues just ready to capture anything coming in towards the trachea or the esophagus that might need some lymphatic awareness. Remember that the palatine tonsils are found within the arch. You've got a palatoglossal part of the arch here, this anterior portion, formed by the palatoglossus muscle from the palate to the tongue. And then you've got the posterior arch here, this palatopharyngeal arch or pillar. This is formed by the palatopharyngeus muscle from the palate down to the pharynx. And here, this is a familiar picture here. We've kind of just removed some of that superficial skin and material there. And here you can see the palatoglossus and the palatopharyngeus musculature. And the tonsils have been removed in this picture here. But a couple other muscles here. We've talked about the constrictors. There are three constrictors, the superior, the middle, and the inferior constrictor of the pharynx. But then there are also three pharyngeal elevators that will help pull the pharynx up when you swallow. So the palatopharyngeus, we've seen already, the palate from the palate down to the pharynx. That's going to help pull it up. There's one called the stylopharyngeus. Let's see if I've got a better picture of that one. Stylopharyngeus is right here, coming from the styloid process down to the pharynx. Oh, no, I'm sorry, that's styloglossus. Here's stylopharyngeus right here. Sorry about that. We're talking about the tongue in this bit. We'll get there as well, but the stylopharyngeus comes more straight down. Stylohyoid, styloglossus, stylopharyngeus coming down this way. Let me go back to this picture here. Excuse me, a better shot of the last one. The salpingopharyngeus is right here, coming down from the bottom of that auditory canal down towards the toward the pharynx as well. So the salpingopharyngeus, stylopharyngeus, which tough to see on this shot here, but then also the palatopharyngeus. Those three are going to be pharyngeal elevators, pulling the pharynx up when you swallow. Here you can, like I said, you can see that tonsillar bed where the palatine tonsils have been removed. We treat tonsillectomies as pretty routine procedures here, but there's actually quite a lot going on here. This could be there could be quite a lot of complication if you don't do this well. That could lead to excessive bleeding. There's several arteries involved. You can see the nutrition bed here is pretty intense. Branches from the lingual artery come right into the tonsillar bed there. Tonsillar branches from the facial artery will also enter this area. Lesser palatine from that the lesser palatine artery is going to have a branch that comes up into the tonsillar bed here, as well as ascending pharyngeal. Remember that one from the external carotid? That's going to travel on the outside of the pharynx and then pierce the superior constrictor here, and then entering that tonsillar bed there as well. If you remove the mucosa here, just under that tonsillar pillar from the anterior and the posterior pillars, behind the tongue, you should be able to reveal the glossopharyngeal nerve here, cranial nerve number 9 as well. This innervates the posterior third of the tongue. It gives a special sense for taste as well as general sensation to that area as well. The glossopharyngeal nerve here, cranial nerve number 9. Okay, let's now look at the, here, actually in this picture too, you can see another one of our terms here, the pterygomandibular raphe, right here. Remember that this is the origin of the superior constrictor, but it's also the origin of the buccinator muscle that inserts onto the upper lip and fascia of the, kind of the fascia and the musculature on the upper lip here of the buccinator. So that's that pterygomandibular raphe there behind, I'm sorry, but kind of between the pterygoid process and the mandible right there. The auditory or eustachian tube, we've seen this already. Remember the it's a bony tube, but it's got that cartilage cap at the end. We call this the torus tuberous, kind of in that nasal pharynx, that where opens the pharyngeal opening of the auditory tube is in the nasal pharynx. And then off of there we saw the levator villi palatini and the tensor villi palatini kind of hooking around. Let's just review that. Remember levator villi palatini coming from the bottom of that auditory tube down to the soft palate, kind of where the soft palate and the hard palate join. This is going to elevate the soft palate. And then the tensor villi palatini from the sides of the auditory tube kind of loops around this hook on the bottom of the, you can kind of see right here, it kind of hooks around the bottom of the medial pterygoid plate on a hook called the hamulus right there. And that's going to attach horizontally to the soft palate. And so together with the levator villi palatini lifting, the tensor villi palatini's job is going to be able to tense that soft palate, to tighten it up, to not allow food or drink to enter the, to kind of pull it up so that nothing can enter the nasopharynx from the oral cavity. But we all know that it doesn't work perfectly because, you know, you can laugh so hard stuff comes out your nose, or maybe you knew that kid in elementary school who could put the spaghetti noodle kind of through his nostril and then out his mouth, and anyway, that's kind of gross too. Let's see, the oral cavity. Let's touch on the oral cavity now a bit here. The vestibule of the oral cavity is basically what Netter's drawn here, kind of lifting up this guy's cheeks, his lips rather, kind of exposing, but it's the area between the teeth and the gums, kind of out, and the lip here. So outside of the teeth and the gums is the vestibule right through here. So if you were to kind of blow up air in your cheeks, that would be putting air in the vestibule here. Oral cavity proper is anything inside of that. So inside of the teeth and the gums is right through there. You can see vestibule would be kind of right up in through here. The parotid duct, we'll see in a little bit here. You can see where that's entering the vestibule right here. That's going to be just lateral to the upper molars on each side, one on each side there. The parotid duct, Stinson's duct from the parotid gland. And then the submandibular duct submandibular gland we'll see is kind of underneath the tongue. It kind of hooks around the mylohyoid muscle, the submandibular gland, and you can see where that's going to exit right on either side of this lingual frenulum, just on the right behind the front incisors on the bottom. And then the sublingual gland is kind of this ridge along the outside here. It's underneath the tongue, but there's multiple orifices kind of leading to that sublingual gland here. Also right here you can see the frenulum of the, let's look at the lip here. You've got an inferior frenulum of the lower lip and a frenulum of the upper lip here. This is just going to be a membrane that helps hold the lips to the gingiva, to the gums. And you also have a lingual frenulum right here, coming down from the bottom of the oral cavity, in the oral cavity proper, towards the underside of the tongue, the bottom of the tongue. This is going to kind of hold the tongue to the floor of the oral cavity. If this gets tight, and sometimes it can get that way just congenitally, how you were born or developed in utero, you can get what they call ankylosing, which is when it shortens up too tight, and therefore the kids that have this will have difficulty nursing. Often that's where it gets picked up, is where they can't quite latch on to the nipple during nursing, and because the tongue is so important with producing some of that suction. Also, if it gets past that point, they might have difficulty speaking, and therefore they may get kind of diagnosed with having some cognitive issues, but that's really not it at all. If this is the problem, it's just that it limits the movement of the tongue so much that they can't speak, or like I said, often you can see this in babies as they have difficulty nursing. But the lingual artery, well, we'll see that in a second here, how it travels kind of underneath here. This travels in the bottom of the tongue, but it sends some branches to these salivary glands. There's these deep lingual arteries and veins in the bottom of the tongue that you'll be able to see because it's been cut in cross section here as well. If we look at the tongue, we showed this picture to show the stylopharyngeus here. Remember, we talked about the stylohyoid. Here's some other muscles now of the tongue. Now, when you think of the tongue, you probably just think of the tongue, this part right up here, but it's really, it's a massive structure. There's a lot going on with, it's much bigger than you might think just by looking inside the mouth here. We've talked a little, I think we talked about the geniohyoid. Geniohyoid coming from those geniotubercles on the inside of the mandible down to the hyoid. That's part of it here. And then there's the genioglossus. Now, if you haven't figured it out, glossus means tongue. So anytime we say glossus, styloglossus, genioglossus is the tongue here. So that's this big fan-shaped muscle here, again, from the genial tubercles inside the mandible and attaching up into the structure here. This is together with the geniohyoid. These are going to help to pull the tongue forward. They're going to, like you're sticking your tongue out. Like when you were a little kid, you were sticking your tongue out at somebody across the room in the class. That's what these muscles are going to do. When they contract, they're going to pull the tongue out of the mouth here. If you can see the lingual nerve here as well coming down. This is going to provide sensation and temperature, touch, pain, those kind of things to the anterior 2/3 of the tongue, right up in front here. And then there's this parasympathetic ganglia. You can see that right kind of underneath the lingual nerve here. You might be able to look at that as well. So what I'd like you to do, you've cut the tongue in mid cross section here. So this is a lateral view of the tongue, a left lateral view here. But what you can do is kind of pull the tongue towards the midline. And then take your blunt probe and start to dissect this area between the tongue and the teeth or the gums in the oral cavity proper. And you should be able to see this lingual nerve now as it kind of translates down into this area, as well as that submandibular ganglia here. This is, again, remember, these are nerve cell bodies of postganglionics that supply glands secreting to the oral cavity. So that's what this submandibular gland is, just underneath the lingual nerve there. A little bit further down, if you keep digging, you should be able to find the hypoglossal nerve. Remember cranial nerve number 12. I don't know why cranial nerve is so hard for me to say. Cranial nerve number 12 is also deep in that area, just in the oral cavity proper, underneath the tongue. Maybe you'll be able to get to there as well. The musculature of the tongue, there are intrinsic muscles, and we should be able to see those because it's cut in cross-section already within the tongue. These help kind of curl and shape the tongue during speech when you're talking. This is what's creating the shapes of the tongue, those intrinsic muscles. And then the extrinsic muscles, we've already touched on a little bit here. Genioglossus, styloglossus coming down this way from the styloid to the glossal area of the tongue. And then there's another one here called the hyoglossus, from the hyoid up to the tongue this way. This is going to kind of help flatten the tongue, but these are extrinsic muscles. These help move the whole tongue because they come from bones, the temporal bone, the hyoid bone, the mandible, and they're going to attach to this. So they're going to actually move the tongue, whereas the intrinsic muscles more just change the shape of the tongue. So the extrinsics, again, the styloglossus, from the styloid process of the temporal bone down to the glossus here, the tongue. This is going to help pull the tongue up and back. You can kind of see the orientation of these muscles. When you swallow, the tongue needs to come up and back to pull that bolus of food back towards that oropharynx. The hyoglossus we've seen right here. This is going to be, you can see here it's been cut as well. Here's the hyoglossus, and it's just been cut, so you can see the structures underneath that we'll touch on in just a second. This is going to come from the hyoid bone up to the glossal tissues there. This is going to help flatten the tongue. When you go to the doctor's office and they say ah, and you can kind of, that'll flatten the back of the tongue so you can see that soft palate and the oropharynx a little bit easier, how it pulls the tongue down. And then we talked about the genioglossus, whose job is to kind of, this really makes up the majority of the mass of the tongue, actually. It pulls the tongue forward out of the mouth. Okay, now you should also be able to see styloglossus and hyoglossus in your dissection today. And there's a little, here's remember the lingual nerve. There's a little phrase I learned from Dr. Shaw. The lingual nerve took a swerve across the hyoglossus. Said Wharton's duct, that's this parotid duct here, the submandibular duct, not the parotid, I'm sorry, submandibular duct here from the submandibular gland. Said Wharton's duct, I'll be a schmuck. The guy has double-crossed us. It's kind of a silly phrase here, but you can see how the lingual nerve is going to come across Wharton's duct here, the submandibular duct, and then go back underneath it to innervate the tongue. So if you see a structure here kind of swerving in and out, kind of interlocked with each other, the lingual nerve and the submandibular duct from the submandibular gland is going to come up there. And here you can see where the submandibular duct is going to exit the mouth just lateral to the lingual frenulum. If I go back to this picture, here you can see where that is here. The sublingual opening, the submandibular duct opening, or Wharton's duct as sometimes it's called. So there's that there. Let's see. The lingual artery is also right here. That's where the netter has cut the hyoglossus. This is going to be underneath. It's going to be deep to the hyoglossus. So if you can, you might be able to see that there, but then you'll also be able to see it exiting here, these deep lingual arteries in front of the hyoglossus coming up there. Also, the lingual vein and the hypoglossal nerve, these are out on top of or outside of the hyoglossus. So you can see the lingual artery there, but then the lingual vein and the hypoglossal nerve are outside of the hyoglossus. And remember that hypoglossal nerve, cranial nerve number 12, is motor innervation to the tongue. So all those muscles that are moving the tongue, that's where that's coming from there. Okay, let's look at one more slide here. I told you this was going to be a fairly quick one. The salivary glands. We've already seen the parotid gland, this big one on the outside. We pretty much saw, this was maybe the first thing we saw on the first day of dissecting the head and neck. The parotid duct, also called Stinson's duct, that was that big duct there. Everybody should find the Stinson's duct there. Travels in front of the masseter muscle and then empties into the oral cavity, into the vestibule, just lateral to the upper molars in front of it kind of pierces right in front of the masseter muscle there. This creates a significant amount of saliva for the oral cavity. And again, this is why plaque gets built up so quickly back in the oral cavity there. From here, right there, you can see where the opening of the parotid duct is going to enter. Go back to here. The submandibular glands, this is right here, you can see the submandibular gland. It kind of loops around the mylohyoid muscle right there. And then the submandibular duct, here's that facial nerve, took a swerve across the hyoglossus, remember that? And that's that Wharton's duct here, or the submandibular duct, is going to come up and around and then enter the oral cavity proper just underneath the tongue there. So lateral to the lingual frenulum. Maybe you knew somebody, maybe you were one of those cool people in middle school who could contract the myohyloid muscle and put pressure on that duct. If you can contract this and put pressure on that duct, sometimes you can get saliva to squirt out of that duct there. When I was a kid, we called that gleeking. If you could gleek, I could never do that, but I always wanted to. That looks so cool. But I was never that cool. So that's what you're doing right on the bottom of that duct there. And then the sublingual duct here, this is on both sides. This big ridge underneath forms a bulge on the underside of the tongue on either side of that lingual frenulum, and has multiple openings. You can see how Netter's drawn all these little openings here to release saliva under the tongue. So when you have saliva under, usually you can find saliva underneath your tongue. This is why when people have if they put a nitro pill underneath your tongue, if you've had a heart attack or if you're having heart issues, it's easily absorbed. There's lots of nutrition, lots of fluid underneath here because of, look at all this glandular tissue producing saliva under here. Even if you've got a dry mouth, check under the tongue. There's probably some there. Now, except in severe dehydration. So this is a good way to check, especially like in babies, if they've been vomiting or excessive diarrhea. You might just stick your finger underneath their tongue. If this is dry, that's a sign of concern that they need to get some fluids. So they may need to get to the hospital. Or just get some care that they're getting dehydrated. But that's a nice way just to see how your hydration is. Well, that's enough for today. Pretty easy. We've got one more to go, and I thank you for your time today. I hope this was helpful, and I'm sure we'll talk about it more in lab. Thanks, everybody. Have a great rest of the day.